I want you to be able to visit with your peers and say, well, hemorrhoids present like this, fissures present like this, fistulas present like this. This is how you, this is the pathophysiology, and this is how you treat them. So here are the things we're going to cover. For rectal pain, an examination is essential. If anyone comes in complaining with pain in their rectum, you got to take a look, and you've got to figure out. Well, we'll go through what you're going to figure out, but you've got to do an exam. You can't be guessing based on the history. So there are a couple of things you can do, a couple of ways you can examine the rectum that makes sense. In PhysDi, I think they'll tell you that women will be most easily examined and most comfortably examined if you lie them or lay them on their side, on the table, have them roll up on their side, and then raise the buttocks on the top out of the way so that you can see what's going on and examine with the other finger. For men, the way I examine their rectum is to bend them over the table. And then I sit on the stool so that I can get a really good look. That way I can use both hands to separate their buttocks, and then I've got a much better look and can examine it easier. Either one of these are fine, and you just have to take a look. All right, so we're going to start with a couple of syndromes where there's only a history and there is no physical finding. And these are sort of lumped into a category of muscle spasm syndromes. So the patient comes in complaining that they have had pain. They usually don't come in complaining of pain now. But they come in saying, oh my God, I woke up a week ago, I woke up in the middle of the night with an unbelievable pain in my rectum. It felt like it was right in my anus. It felt like it was some people call it the worst pain they've ever had in their lives. This is not a common phenomenon. This is a relatively uncommon. You know what the incidence is, Sally? I don't know, but it's pretty uncommon. In fact, when I've brought this up with colleagues, most of them don't know what I'm talking about. Professor Rourke is one of the first clinicians I've come across who knows about it. She asked me yesterday, are you going to talk about proctalgic Fijax? So it's an uncommon phenomenon, but there are a couple of things about it. It's real. It is. There are no physical findings, and there are some treatments that work. So you ought to know about it. One of them is the levator-ani syndrome. So the levator-ani muscle wraps around the anus, and when it gets inflamed, it can go into spasm. I don't know if you remember this. Maybe you haven't been told this. The whole GI tract, from the stomach to the anus, has no pain receptors except for distension and squeezing. Those are the only ways the GI tract causes pain. You've been aware of that? Mm-hmm. Okay, so when something wraps around the GI tract and squeezes it, it's going to hurt. All right. So levator-ani syndrome is a syndrome where that muscle goes into spasm and squeezes.
Estimated prevalence 8 to 18.
8 to 18%. Wow.
High, but it's underreported.
Underreported. Well, you know, I've mentioned it to. I've had it personally. I've had the proctalgic Fijax personally. In a severe form, I mean severe form. And when I mention it to my friends who are physicians, they kind of go like that. They don't know what exactly what's, I think I've had that. But it's really mild. It's really mild. It wakes them up in the middle of the night, they've had this pain, and then it just goes away within a few minutes. And that's the usual presentation, but people come in because they're worried that something bad is happening. Elevator anus syndrome generally has a little bit of tenderness when you do a rectal examination, has a little bit of tenderness when you do the rectal examination and push your finger around. There's usually some tenderness there. On the other hand, proctalgia fugax is a spasm of the muscle that wraps around the rectum, okay? And when it goes into spasm without any inflammation of this muscle and squeezes the rectum, and it feels like the patient can figure out that the pain's right in the rectum, and yet they don't need to defecate, they don't need to pass gas, it's just there. Most of the time, it goes away within 20 minutes. Sometimes it doesn't. Mine does not go away within 20 minutes when I have it. And you can use muscle relaxants to help this. Professor Rourke told me yesterday that in her GI practice you used cardizone.
Long-acting cardizone in patients that were having it frequently.
A lot. So they put them on cardizone and left them on it, just daily cardizone for 4 or 5 months, and then when they didn't have any more, they just sort of weaned them off of it and didn't come back. I personally use Levsin, which is a homocyanine tablet that is generally used for irritable bowel syndrome. It's a smooth muscle relaxant. And I've only used it in myself. I've never used it in a patient because I haven't had a patient that's had this as bad as I have. And I haven't had a patient which didn't go away in 10 or 15 minutes. But I've never had Levsin fail for mine. So this is evidence of one. Weak evidence. All right, so for the rectal examination, before you start seeing patients with rectal diseases, you probably should review the anatomy so that you've got in your head what the anatomy looks like, where the external sphincter is, what comprises it, what the internal sphincter is, what comprises it, and these layers of muscle. Those are difficult to sort of carry around in your head, but you should review them, especially as we're looking at these diseases. So here's sort of a cartoon of this anatomy, and you can study this a little bit on your own later. But is this a... I don't know what this is. Okay, so where those little fingers are coming down in the middle there, that's the dentate line, and that differentiates really the exterior to the interior. And many of the diseases are classified either being above cephalad, above that, or proximal to that dentate line, or distal to that dentate line. Okay? You can also think of the sphincters, the anal sphincters, the external and internal sphincters, as being anatomically related to the dentate line. So the first illness that we're going to talk about are hemorrhoids, and they are classified as external and internal. And this cartoon sort of reiterates what I just said about the dentate line. the external hemorrhoids are always distal to the dentate line. They are always visible when you do your examination. If the patient comes in and says they have rectal pain, and you do your exam, and you see a hemorrhoid, it's an external hemorrhoid, unless it's a huge internal hemorrhoid that's protruding. But 99 out of 100 times, if you see a hemorrhoid on exam, it's going to be an external hemorrhoid. And then the internal hemorrhoids are, like the name implies, proximal to the dentate line, and seldom do they protrude. So here are some examples. This is an external hemorrhoid. Here are two other examples. So what are hemorrhoids? Hemorrhoids are a collection of vessels that have dilated. Vascular connective tissue, they form a plexus of dilated veins, and these veins dilate, and they can become inflamed and cause pain. Hemorrhoids commonly cause pain even if they're not severely inflamed. Now the internal hemorrhoids are coming off of a set of veins that are connected to the portal circulation. Have you studied? You've studied the portal circulation in anatomy, right? Mm-hmm. So internal hemorrhoids are in a venous complex that are situated in the portal circulation. The external hemorrhoids are a set of veins connected to the systemic circulation. So you would expect someone with high pressures in the systemic venous circulation to get external hemorrhoids. You would expect people with high pressures in the portal system to get internal, right? So what disease do you worry about for internal hemorrhoids? Cirrhosis. You worry about liver disease, right? Liver disease causes pressures to rise in the portal venous system and therefore might result in internal hemorrhoids. What disease would you worry about for pressures in the systemic venous system? Hypertension, no. Mostly hypertension would be on the arterial side. What causes pressure to rise on the venous side? Congestive heart failure? Yeah. Congestive heart failure, what else? What? Anything else? Pulmonary diseases. Pulmonary diseases cause pressure to back up on the right side of the heart. Anything that causes right-sided heart disease will cause pressures to back up in the systemic venous systemic venous circulation, right? So people with chronic congestive heart failure might present with external hemorrhoids. They commonly cause pain, and they're caused by increases in pressure in the venous system and increase in pressures in intra-abdominal pressure. So, two things that cause increased abdominal pressure are chronic constipation, pregnancy, ascites, obesity, heavy lifting, space-occupying lesions within the pelvis. Any of these things can increase the pressure on the venous system down below in the pelvis. That makes sense? These are almost mechanical causes. And then you have increased pressures within the venous system, which is what I was just talking about. Internal hemorrhoids, cirrhosis, and other causes of liver disease. On the systemic side, you have congestive heart failure, chronic pulmonary disease, and inferior vena cava obstruction. All that makes sense to you? So you can imagine test questions that might ask you to tie external versus internal hemorrhoids to which venous system has the higher pressure. On the other hand, either internal or external hemorrhoids could be caused by the things on the top list, right? Because these things on the top list are just mechanical things that cause the pressure in the venous system down low to go up. They're more commonly in the elderly. They're uncommon in children. When you find them in children, you have to look for systemic and portal causes. Because they're so uncommon, they're really unusual. You really have to pay attention. Pregnancy considerations, they're common in pregnancy because of this increased pressure in the pelvis. And they usually just go away after delivery. Unless they're painful, no treatment is required of hemorrhoids caused by pregnancy. So, treatment. Like all things in medicine, you try to think of what's the cause. And then your therapeutic goal is to decrease the cause. For acute pain, things you can tell them in your office, they can take sitz baths. You know the term sitz baths? I don't know where the term sitz comes from. Sit down, I don't know, you know the origin of that term, sitz bath? You put some hot water in the bathtub and sit in it. Sitz bath.
Therapeutic sitting in the bath.
Therapeutic sitting. Over a long period of time, you can increase the fiber of your diet so that you decrease the presence of constipation. Acutely, one can use steroid cream. I find that just Cordaid over the counter works just fine. It's 1% cortisone cream over the counter, and you can just have the patient buy some Cordaid cream, and once a day or twice a day put a little bit of that on the hemorrhoid, and it commonly is enough to decrease the inflammatory response so that it either just goes away or calms it down enough so that the pain is tolerable. Cordaid is a magic medicine for many things. If steroids fail, then you can attempt rubber band ligation. So the way this works, have you done that? I haven't either. I always get my surgery colleagues to do what?
Refer to colorectal surgeon. Yes.
Yeah. I always get my surgical colleagues to do all these things. But I think they have a little gadget, don't they? I think they got a little gadget that has a little rubber band on it. They put it there and snaps the rubber band on it. So now you've got a rubber band tied around the base of the hemorrhoid, and it just cuts off circulation, blood supply, and pretty soon it just falls off. Change your underwear, and it just winds up in your underwear instead of on your body. I don't know really, except it works. Hemorrhoidectomy, if none of these things work, then you have to have a surgeon, colorectal surgeon, right now, but I think I won't perform a hemorrhoidectomy surgical procedure. Indications for hemorrhoidectomy are repeated blood clots, if the ligation fails, protruding hemorrhoids that can't be reduced. What do we mean by that? You've got a hemorrhoid, usually external, that protrudes outside the anus. If you can't get it to go back in, and it just simply will not be reduced, and that's an indication to have a surgeon remove it. They'll first try to ligate it, and if they can't remove it with ligation, they'll surgically remove it. And you know, these things are just comfort issues. I mean, if you've got a hemorrhoid hanging outside the anus, it hurts to sit down, it's uncomfortable to walk, I mean, it's just a problem. And then there's a clinical syndrome called a thrombosed hemorrhoid. A thrombosed hemorrhoid is that the hemorrhoidal tissue, that collection of veins that we call the hemorrhoid, develops a blood clot within the hemorrhoid. Okay, so it's a thrombosed hemorrhoid. And that almost always presents as an acute problem. Patient comes in and says, man, I woke up this morning with really bad pain in my rectum. You examine them and they have a hemorrhoid that is no longer soft and pliable and painless. It is hard and it's really painful to touch, okay? Because it has an acute new clot inside it. And that generally, if you can't get it pushed back into the anus, requires referral to a surgeon.
Or an 11 blade.
Or what?
Or an 11 blade.
Okay, so I don't use 11 blades. I'm allergic to knives. But someone, probably a gastroenterologist or a PA who does GI, might open it up. And if I've in fact had a surgeon open one in my clinic, and I was amazed at how rapidly it resolved. You simply stick a hole in this thing with a scalpel, squeeze it, the blood clot pops out, and you're done. It fixes. Yeah. So you all can do that. Give me a text when you do that, and you're so pleased with yourself. I will not be texting you.
And your patient will thank you. I mean, that.
Yeah, they'll be really pleased.
Really
pleased. This is also a situation where you wouldn't use a xylocaine, right?
Nope.
The xylocaine would hurt worse than getting it out. So you just stick a needle in it, or stick a scalpel in it, pop it out, call Sally.
I'll talk you through it over the phone.
There you go. You got your, what? To do what? Where? Okay, anal fissure. Anal fissures are longitudinal tears in the lining of the anal canal, distal to the dentate line. And you can usually see them on exam. You can usually see them when you separate the buttocks and get a good look at the anus. You can see a place in the anal verge where there's a fissure. It's a bright red or brown streak in the anal fissure, in the anal canal. It's a very common benign anorectal condition. It's sometimes confused with hemorrhoids, especially if you don't do a good exam, because it feels the same as a irritated, inflamed hemorrhoid. We classify them as acute if they're there for less than 6 weeks. We call them chronic if they're greater than 6 weeks. Those are sort of arbitrary things. Anal fissures affect all ages. They're common in infants from 2 to 24 months, and it's almost always associated with constipation in little kids who have to strain to have a bowel movement. They create these tears in their anal mucosa. Less common in elderly people, but you'll see them in all ages. High pressure within the anal canal, usually as a result of straining, but also as a result of trauma. It leads to ischemia of the anoderm, resulting in splitting of the anal mucosa during defecation. So every time, if someone has one of these, it's inflamed. So what you've got is a tear. Now it's inflamed, and you can imagine how difficult it is in the anal canal to keep it from being inflamed. It's sitting adjacent to tremendous amounts of bacteria all the time, and so you can't clean it up, so to speak. So until it gets healed, it's going to hurt every time one defecates. Risk factors are passage of hard or large stool, high resting pressures, prolonged sitting in the stool, or obesity. I don't know why obesity does this. Do you know, Sally?
No, I saw more commonly just in normal.
I don't know why obesity does this. Trauma is common. Trauma is common in my experience. No, that's not true. Trauma is uncommon, but one needs to be aware of the fact that anal intercourse is a cause of trauma to the anal canal. I would say probably not common cause, but it's a cause that one has to be aware of, and part of the history that one would take. Inflammatory bowel disease, Crohn's disease specifically, because Crohn's disease affects the anal canal more than with ulcerative colitis. But inflammatory bowel disease is a cause. And then infection due to these various organisms, mostly sexually transmitted, but also tuberculosis. Constipation, inflammatory bowel disease, Crohn's, TB, leukemia, HIV. Leukemia, HIV are associated with these anal fissures because they are immune compromised. So if you can imagine, the most powerful, most impressive thing our body has to fight infection are called polymorphonuclear leukocytes. I mean, the white blood cells are awesome. And the white blood cells and the lymphocytes basically keep us from getting infected 24/7. They're much more powerful at fighting infection than antibiotics. So if you're immune compromised, you're at real big risk of getting infections. And people with leukemia are immune compromised, people with HIV are immune compromised, there are people who are born immune compromised. So immune compromised states are a big risk factor. So how do they present? They present with pain. Pain on defecation is real. They commonly see bright red blood. They might see only bright red blood on the toilet paper. They might have felt the tearing sensation when it happened. And they might present with spasm in the anus. So they might present with a syndrome that sounds like amaurosis fugax. I don't mean amaurosis. Rectal fugax. But spasm, and when you do an exam, you'll see the fissure. So here's a picture of the fissure. The fissure's down at the bottom of the slide. You've got this tear distal to the dentate line, and you'll see it almost every time. So treatment: avoid repeating the tear. Wash gently with warm water daily. High fiber diet, stool softener, and then you can use some of these things to try to calm down the spasm of the anal canal. I've never used botulinum toxin on this, have you?
Dr. Corella had used it a few times.
In chronic cases?
In chronic cases, yeah.
So this would be injected, right,
Yeah.
into the anal canal?
And then he also used the nitroglycerin.
Nitroglycerin paste. Yeah.
Or paste, yes.
Nitroglycerin paste is really difficult to use. It will work here, but it's so difficult to use because of headache. Nitroglycerin paste causes headache. I used to watch, when nitroglycerin paste first came out, I was a resident, and we were using it in the coronary care unit, and we would rub it on people's chest. It didn't really matter where you rubbed it because it's absorbed and acts as nitroglycerin, so you could rub it on their ears and it would do the same thing. And I noticed that the nurses who were putting it on always had on gloves. And I thought, that's kind of silly. You're just rubbing this stuff on their chest. I mean, you don't need a sterile procedure. That's crazy. What's wrong with these crazy nurses? So patient came in, nurse was busy. I laid the patient on the table. I squeezed out the nitroglycerin and rubbed it in. And I mean, I got the worst headache I have ever had in my life and was kind of weak-kneed. My blood pressure dropped. I had headaches so bad I couldn't attend to the patients. That took me forever to get, it took me an hour to get rid of it.
Dr. Vanetta.
Yeah.
So I know that that's a vasodilator, so why does it treat an anal fissure? I can see where it might treat a hemorrhoid, but. Or like the calcium channel blockers.
Yeah, calcium channel blockers, let's see. Calcium channel blockers will help with spasm. Nitroglycerin will,
I think the idea there is to vasodilate it enough so that you can get healing to happen. I think it's more to treat it, because that's the problem with those fissures, is they just won't heal. Every time you go to the bathroom, they rip open again. You go to the bathroom, they rip open again. So,
Gives it more elasticity.
right, it's just more to let to relax it so the tissue can meet.
so you think it's a muscle relaxant rather than a vascular?
Well, I think it's both. I'm gonna see what.
You know, I don't know the answer to that, but I will find out. Great question.
I bet I can give you an answer.
Here's what I suspect we will find. Nobody knows. I suspect we'll find, no one really knows why it relieves pain. But
There's no evidence-based medicine on
Right,
it.
right. So we're going to begin talking about evidence-based medicine. Well, the fact is, and this is a true fact, there isn't evidence. There isn't evidence for most of the things we do in medicine.
This probably makes more sense. So your other option is to do a sphincterotomy. To go in and just cut the thing open and let it relax. I would probably take the nitroglycerin paste, relaxing things, over a sphincterotomy. So you would only use it in people that have had chronic.
So probably it's to relieve the spasm
Yes.
in the anal canal,
Right. Right.
so that you can buy some time,
It'll relax and then it.
decrease the pain, buy some time to heal.
Because it almost, if that tissue keeps tearing and healing and tearing and healing, it gets stenosed. And so the rectum will get stenotic, and then that's just creating more fissures, because now you've got a tight outlet, and so you're having to tear it back open every time you go to the bathroom. I mean, it's a bad problem when people have it chronically.
I suspect that's the reason we use it, is muscle relaxant.
Yeah.
That's how it works in angina, is a vasodilator and muscle relaxant. Causes vasodilatation by relaxing the muscle in the vessel. Okay, a fistula. So a fistula is different from a fissure in that it's an open communication between an anal abscess and perirectal skin. So what's happened here is that somewhere up in the anus or in the rectum, you've developed an abscess in the mucosa of the bowel, right in the muscle, right inside on the mucosa of the rectum or anus, or just inside in among the muscles, you've developed an abscess. And the abscess has, over time, created a tunnel. The inflammation will tunnel through the skin, sometimes through the fascia, and it'll exit out somewhere in the perirectal skin. Okay, so you have this abscess. It's a fistula tract. And the literature suggests that they start with occlusion of these anal crypt glands. The anal mucosa has little things called crypts, and there are little glands in there, and if those get obstructed, then the gland can't get rid of the stuff it's making. It's associated with bacteria all day long, and a little abscess gets formed. An abscess, by definition, is a closed-off infection. So it's just sitting in there, it can't go anywhere. Pus, here's a rule that you can live by. Pus under pressure must be relieved. Pus under pressure has to be drained. And that's what the body's doing if it develops an abscess in a little anal crypt, is it's finding a way out. More times than not, it'll burst open and drain out through the rectum, and those pesky polymorphonuclear leukocytes and lymphocytes will heal the infection. We probably all have this going on periodically all the time. But if it won't open up to the canal, to the rectum or the anus, then it'll find another way out, and it'll just literally force its way and eat its way through the muscle, the fascia, and find its way out to the outside. It just shows up in the perirectal skin. And you see these, you'll see the fistula, not in the anus, but over to the side, what we call perirectal tissue. Does that make sense? So there's submucosal, superficial, blah, 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 blah. Now, these four things, intrasphincteric, transsphincteric, suprasphincteric, extra, you don't have to memorize those at all. I just want you to know that this is the way they're classified. Don't memorize those things, okay? All you got to do is recognize that there's a fistula or an abscess or something on the skin. If you see an infected skin there, you have to wonder, is that a superficial infection, like a pimple? Or is that the opening of the fistula? That's your concern, not what relationship does this fistula tract have with the finger? Because you just don't want to miss a fistula and treat it as a pimple. So don't worry about that. You're not going to be tested on that at all. Okay, so debris obstructs an anal crypt gland. It results in suppuration of abscess formation, and then it comes out, as we talked about a while ago. Risk factors are, again, inflammatory bowel disease, pelvic radiation, perianal trauma, pelvic carcinoma or lymphoma, abscess formation due to acute appendicitis, salpingitis. Salpingitis is fallopian tube infection or diverticulitis. So any other infection within the pelvis can set the patient up for an anal fistula. And again, anything that causes an immune compromised state. Cancer treatment, so HIV infection. So you look for redness and expression of pus. And again, the thing you might see, you might think is just a pimple, might be the opening of a fistula. So you have to just be aware that this might be more than it looks like, okay? And then you have a couple of other things that are really uncommon, but you certainly don't want to miss because they have to be surgically corrected. This fistula tract that comes out of the anus or rectum can get out into the tissue and back into other pelvic organs. So it can open back up into the vagina, and it can open back up into the bladder. So you might wind up with a rectovaginal fistula. You might wind up with a rectovesical fistula. A rectovesical fistula is a rectal bladder fistula. And the patient might come in and say, I am really embarrassed, but I got this weird symptom. When I urinate, I pass gas. It sounds like I'm passing gas when I urinate. You have to worry that what's happening is that gas from the colon is getting into the bladder, and then when they open the valve to urinate, they hear the gas come out. Women who have a rectal vaginal fistula might notice really, really bad smelling discharge. There may be pus coming out, and sometimes gas comes out, or stool from the vagina. So these have to be surgically corrected. One of the tip-offs to a rectal vesicular fistula is a urinary tract infection that won't clear up. So the patient comes in, they look like they have a UTI, you culture their urine, they got E. coli in the urine, which is the most common organism in a urinary tract infection. You treat them, and they don't clear up. You treat them, and they don't clear up. You treat them, you don't clear up. So you have to ask yourself the question, where in the world is that E. coli coming from? Why aren't we killing them? If they've got a fistula from their rectum into their bladder, you can't cure it. All right. So, what are the diagnostic modalities for an anal fistula? They are the ultrasound, which is where you would start, a fistulogram. So if you found a fistula with an ultrasound, surgeon might want to do a fistulogram. He'd have the radiologist put a small tube in the fistula opening out there in the perirectal tissue and inject radiopaque material in it, and then make a photograph and see where the track is. The surgeon has to know where the track is so that when they go in to fix it, they know where to cut. CT of the pelvis, MRI of the pelvis are other things you're going to be using. You don't have to decide which of these you're going to want to use, but you just need to know what the modalities are. You might order an ultrasound to get started, but by that time you will have already probably consulted a surgeon or a gastroenterologist or someone to help you with this. And then bowel rest, skin care, and surgical intervention are the treatments. Bowel rest, I don't know. Did you ever put anyone in PO for 6 weeks to see if this would heal? Probably not a good idea. It's not a good idea to starve someone for 6 weeks. I would let the gastroenterologist and surgeon decide on this, and surgical intervention is probably pretty early in the treatment of most of these things. And then anorectal abscess. This is an abscess that's outside the canal in the soft tissue, but has not created a fistula tract. Okay, and it's usually superficial enough that you can see it. Presents with pain. They usually have fever, a high white count, labs consistent with infection, which is a high white count. Most are perianal. And some, if they're perianal, you'll be able to see them. It'll be a red skin. It'll be a bulging thing. They'll be sick. They'll be, and you'll be able to touch it. I once showed up for check-in rounds. I did check-in rounds at 7:30 every morning for 13 years at one of the hospitals at the Health Science Center. So 7 days a week, I'd meet the intern for breakfast at 7:30 in the morning and talk to him about the patients they had admitted the night before, and then go see the patients and see how they did and so forth. One morning I sat down with the intern and he started telling me about his night, and he was sweating, and he was